Thank you, Eric, for your kind introduction, and thank you to be part of this webinar. It's a great honor for me. So I'm talking about the chronic iatrogenic spinal CSF leaks. This is a diagnostic and treatment options. And this is a European or respectively a Swiss perspective. So I have no disclosures. So coming shortly to the etiology of the CSF leaks. So we have the spontaneous intracranial hypotension, and we all know the different types, which was described by Walter Schieving. Type 1, type 2, type 3, and type 4, it's intermediated. And we have those iatrogenic CSF leaks, which mean post-dural puncture headaches. And there are also some postoperative CSF fistula and maybe shunt over drainage, but I won't talk about this. So in the German-speaking countries in Europe, we have some German, Austrian, and Swiss guidelines for the diagnostic and therapy of the post-dural puncture headaches, and also for the spontaneous intracranial hypotension. So these guidelines give some recommendations concerning the diagnostics. And as mentioned previously, they talking about or writing about a typical clinical presentation after lumbar puncture within the five days after. And also there's radiological workup with indirect and direct signs of a CSF loss. So also the goal of the diagnostic should be the exact localization of the CSF leak site. So in PDHD, there is no specific diagnostic strategy compared to SIH. Coming to the treatment, they recommend a body positioning, that means bed rest, some medication, as Fanas already mentioned, doing epidural blood patches, Ian talked about it, and finally, surgery. However, so spinal CSF leaks must be clearly localized beforehand surgery. And this is really a rare condition in many patients with PDHD. So coming to the diagnostic workup, I want to start with the SIH. So as mentioned before, there's a classification described by Walter Schieving about 3 types of CSF leaks. So meaning there's a discogenic microspur, there might be some arachnoid cysts or a CSF venous fistula. And what is the issue about diagnosing SIH? You have to pinpoint the exact site of the CSF leak. And the diagnostic challenge in this case is you have a potential CSF leak, which can be located along the entire spinal axis, and you have 3 different pathologies to identify. So this is a challenge. So in former days, we started in Bern with this diagnostic workup for SIH. So we had a stepwise protocol that developed during we treated more and more patients. And so finally, we found the reason is in 80% a discogenic microspur and in 20% arachnoid cysts. In these former days, we had the focus on the CSF venous fistulas, but which is nowadays the case. And so we had a good hit rate with this diagnostic workup to exactly see the site of the CSF leak. Now you know where to search, but you cannot visualize the pathology. That is the problem right now, and this reminds me a little bit on Shackleton's on the story on Shackleton's ship Endurance. So the Endurance sank in 1915 in the Arctic, and it was located. It wasn't located until 2022, when satellites identified the ship at a depth of 3,000 meters and only 8 kilometers from the location documented at the time of sinking. And this is almost the same. You know you have to search for something and you know the location, but you can hardly visualize it. So coming back to using the standard diagnostic for SIH in PDHD, and you have different modalities. So the standard will be a cranial and spinal MRI. And the matter is you do not see direct or indirect signs in CSF leak. It is predominantly negative. And in mostly cases have no defect at the puncture site, which is visible. And the dynamic myelography or post-myelo CT, you have to do a lumbar puncture for contrast medium, and this carries the risk that you will have a false positive result for CSF leak due to your diagnostic workup. Coming to the digital subtraction myelography, which is the modality to identify the CSF venous fistulas. This is a very rare condition, in my opinion, in addition to the PDPH. It's really rare, and it only has to be excluded in second line, or that means in refractory cases. So another modality, diagnostic modality, would be the radioisotope cysternography. And this might identify a CSF loss syndrome, but however, the exact determination of the CSF leak site or the anatomical dural defect is right now not really possible. Maybe this, I think this technique will advance and give us a better opportunity to identify the leaks. Coming to the treatment, so we also perform a stepwise treatment approach, starting with bed rest, some supportive medications, blood patches, and finally surgery. And in case of PDHD, it's explorative surgery. So an epidural blood patch, how is it working? So I think there are two theories. The first theory is closing the leak by sealing the dural defect with a fibrous transformation. I think this is really hard to achieve. I think the effect of a blood patch is more the epidural compression of the intracecal volume and therefore decreasing the compliance of the cecal sac. We have a relatively good efficiency on epidural blood patches. It works in around about 70%. Several techniques, which are already was mentioned by Ian. You can do target blood patches, you can do untarget. We do almost in every case untarget blood patches. You can use blood versus fibrin. We always use blood only. So you can use a low versus a high volume. You should at least achieve 20 cc's to 40 cc's as volume. And you can perform ventral versus posterior puncture. But so I think in many cases, posterior will be fine, posterior puncture. So what are the indications for surgery in PDHD? The common situation is you have an inconclusive radiological workup and you have severe suffering patients. And the psychological aspect is really severe in those patients. So don't get distracted by the psychological aspect, first of all, of the patients, and be guided by a consistent patient's history. And then do multiple previous blood patches that provide at least temporary improvement. And even if radiological workup doesn't show what you'd like to see. And this is a clear dural defect and or CSF regress, indicates surgery in persistent symptomatic cases. So we described the surgical strategy in CSF closure in SIH, and this was also a straightforward concept because we knew the pathology, and we did a small fenestration or hemilaminectomy coming from one side. We can open the dorsal dura by rotating the spinal cord. Under intraoperative monitoring, we can visualize the pathology. In this case, it was a microspur, and you can close it. So strategy repairing the dural leak was quite clear and straightforward. So in cases of PDHD, in my opinion, it is really in most cases surgical exploration. And so you do not know in many cases the exact pathology, and therefore you have to maybe explore 3 levels, because 3 levels, that would be that would be the area where the lumbar puncture was done, and I do it with a unilateral interlaminar fenestration, showing this intraoperative picture. Coming from one side. And you have to explore the visible dural circumference, which is the dorsal part or dorsolateral part of the dura. And so finally, if you can locate your CSF leak, you can close it. But however, so there are various morphologies of dural defects. It was already mentioned, arachnoid bleb, that is circumstances which you can see quite well in the preoperative imaging. So as you can see here, there is a defect in the dura, and the arachnoid is bulging forward. But you can also have, as described by Wouter, a ventral dural leak. In these circumstances, this is a transdural approach, and you can see the nerve root coming out, and there's the small hole in the ventral dura. And you have a basic dural defect. This is a small dural defect, and there's a really thin layer of arachnoid, and normally there's almost no CSF flow during surgery. And you can have real complex dural neosacs, as described in this case report, with a duplication of the dural sac, and so quite amazing what to find during surgery. So next step is taking care of the invisible dural circumference. And this is a part which you cannot see. This is your blind spot. And therefore, I think even if you find a posterior pathology and the diagnostic workup is negative and you cannot identify an anterior leak, just to be sure, I do 360 degree wrapping of the dura with a dura augmentation just to close your blind spot. So coming to the conclusion, diagnostic in PDHD is very challenging and often CSF leak negative. Nevertheless, take the patient seriously. Do not make a hasty psychosomatic diagnosis. Try to narrow down the puncture site by clinical landmarks and diagnostics, and don't miss the indication for explorative surgery. So I want to give some thanks to the Spinal CSF Leak Canada and all the dedicated patients, my administration and the radiology in my hospital, also my former colleagues from neurosurgery Freiburg and neurosurgery and neuroradiology in the Insel Hospital. Thank you very much.